All right, guys, we got Dr. Klauer back again. He was talking a little bit more in depth about sleep last time and how that relates to your overall health and your oral health. Today, we want to dive in a little bit more to disorders of the jaw joint. There's all kinds of misunderstandings about what's normal, what's not, when should you treat it, how should you treat it. And there's some different camps and some different theories. And part of the educational process that Dr. Klauer put himself through was to help figure out those different things and figure out what's best. You know, it's not normal to be in pain and to live your life in pain, and there are some options out there. So I'm going to let him talk through some of these because he knows it much, much better than just about anybody else out there. So Dr. Klauer, thanks for coming back.
Thanks for having me again. So the disorders of the jaw joint kind of fall under the umbrella of TMJ. And so what TMJ is, the temporal bone here, the mandible bone here, and the joint. So temporomandibular joint is the TMJ. We have two of them. When people say TMJ, what they mean is a dysfunction of that joint. Kind of like saying I have shoulder. Now we say I have a shoulder dysfunction, whether it's a inflamed bursa, torn labrum, rotator cuff, whatever it is. So disorders of the jaw joint now is kind of adapted the term TMD, temporomandibular joint dysfunction or disorder. The whole nuance of it is kind of like a little bit of an orphan child to an extent. In the 70s, it was kind of owned by even before that, it was coined first by the ear, nose, and throat physicians, because a lot of otalgia, ear pain, manifested as joint pain, and we didn't know which was which. Was the ear causing the jaw to hurt, or was the jaw causing the ear to hurt? And so the way the ENTs got it off their plate was, well, that's a TMJ problem. That's a dysfunction. Did I lose you?
Oh, we got you. We're back.
Oh, sorry. So a lot of ear, nose, and throat doctors weren't sure if it was a dysfunction of the jaw joint or not. So what they did was they kind of referred those out. And they said, oh, well, that's a joint, so let's go to orthopedics. Well, orthopedics guys, they don't really have surgeries for that. So it didn't really live long in that camp, if you will. So we thought, well, who's the next best surgeon? Oral surgeon. So we sent TMJ patients to the oral surgeons. Well, the oral surgeons in the 70s did a bunch of surgeries. They took out a lot of cartilage discs and put Teflon grafts in, and then they found out Teflon was not good for joints, and then they took all those Teflons out. And then they went through this hysteria of, oh, it's got to be about the bite. So when it was about the bite, what they did was they sent it to the orthodontists. And so all the orthodontists did the great work they do, and they made bites perfect. But then the dysfunction came back. So then, like, oh, well, let's send this to the general dentist. So they send it kind of to the general dentist, and you just manage your patients. And I don't know about you. I do know about you because we were in school together. But in school, we were taught, basically make a flat plane guard, put it in the patient, and then right before the patient gets out of your chair, say a prayer and hope that they never bother you or come back with that problem, and then it worked perfectly. And then you're good to go. If it doesn't work, I don't know, find somewhere else to send them. And so that's basically our education in TMJ as most dentists coming out of school. So we're in this no man's land where a lot of it got pawned from dentists to physicians and physicians to dentists to physical therapists. And the actuality is we all need each other to treat this. So in our practice, what I've found is most jaw joint dysfunction is secondary to either a nasal obstruction or a breathing disorder or a chronic pain issue. So nasal breathing dysfunction, sleep disordered breathing, which is abnormal breathing at nighttime, is associated with the stimulation of clenching bruxism, and it strains the jaw joint complex, creating dysfunction. Chronic pain, low back pain, knee pain, hip pain, all stimulate you to brux or clench. And at nighttime, we clench 5 times greater than we even can at during the day. So that's a lot of time when the damage occurs. But really what's happening in a lot of these issues is there's a muscular problem where the muscles are fatigued or in spasm from the excessive force, or the cartilage gets kind of compressed out of place. And now you don't have that cartilaginous support in there like you need in all the joints. And you can even get as far as coming into like an osteoarthritic situation.
Man, yeah, it's just not as simple as maybe we were once led to believe, you know. So what's the first step for someone if they've had this chronic pain? Let's say they had a night guard and they've tried different night guards and nothing seems to work. What can we tell our patients?
So one of the first things to do is find a practitioner that can do a thoughtful, thorough examination to look at that. So we want to get a status of, is there osteoarthritis? Is the cartilage in or out of place? Because that'll have us go one direction versus the other. We always want to make sure that these patients can breathe adequately through the nose, because a smooth nasal breathing pattern is essential to keep the face calm and relaxed. And we all have experienced that. Anybody who has ever caught a cold feels facial pain to some extent. And you'll say, oh, well, you're holding your face. What's wrong? Oh, yeah, well, I have a sinus congestion, so my face hurts. That doesn't surprise us. But yet when sometimes we tell patients, oh, you have jaw joint dysfunction because your nose is not working, they're like, well, no, that can't be it. And it can't be it because they don't know. So step one is identifying, is there a sleep issue? Is there a nasal breathing issue? Is there a systemic issue? Something is wreaking havoc in that system. And then you want to go about treating it. So oftentimes our treatments involve physical therapy, injections, customized orthotic that keeps the joint in a stable position. And a splint or an over-the-counter mouth guard is prefabricated. So it's like 3 millimeters and 3 millimeters. You put it in and it's a chew toy. An orthotic is a customized or appliance that is positional, that keeps the jaw in a stable position and allows you to function on it. So not all of us are symmetrical. Some of us are off kilter. So a customized orthotic may be 2 millimeters on one side, 5 on the other, and it's built for that patient. So we're not overcorrecting one side or undercorrecting one side. And so that has to be taken into account. But I'd probably say that the best part of treatment is an accurate diagnosis and identifying what led to the breakdown. The analogy I'll always use, and my team's probably so sick of hearing about it, is if Dr. Brown sends me a patient for tooth wear and joint noise, so the cartilage is slipping in and out of place so much it's making a noise, and that's abnormal. A lot of people have it, but it's abnormal. Just like it's becoming more normal to be overweight, it doesn't mean it's healthy, it's just more normal to be overweight. I'll tell a patient, look, Dr. Brown sent you in because you have tooth wear, pain, and joint noise. That's like you calling a handyman because there's water in your kitchen. And the water now is warping the wood and it peeled some paint off the wall. The handyman can suction up that water with a vacuum and repaint the wall. And then you just call him when the water comes back. Or he can say, do you mind if I look around and find out where this water is coming from? And let's say he finds out there's a hole in the roof. Yes, you need to clean up the kitchen, but if you don't fix the hole in the roof, you're just going to be coming back to fix the problem. So my opinion, in dental school, we were taught to just, put paint over the wall and get the water out and just hope and pray it didn't come back by the, 2 years we were in clinic and dental school. But what we really want to do is treat the initial problem, get them out of pain, protect the dentition, protect the jaw, but also try to take a step further and see if we can figure out, okay, what led to this breakdown? Is there obstructive sleep apnea? Is there nasal breathing obstruction? Is there a chemical substance, nicotine, caffeine, or other drugs, medications that are stimulating that bruxism that's contributing to it? A lot of the ADHD medications stimulate bruxism. And so we have to take all that into account when we develop a treatment plan. Because I say I'd be just as bad of a dentist that doesn't do hygiene if we just made mouth guards. Meaning, if Dr. Brown sees a patient that comes in with 12 cavities and doesn't spend time cleaning the teeth or talking about why they got cavities, he's not going to be doing a good service of just filling the teeth, because it's just going to come back and they're going to break down again.
That's beautifully said. We're all about prevention. We're about fixing the issue, not the symptoms here. So,
correct.
Doc, thanks for your time, man. I know there's a lot going on right now, and you got a bunch of little ones running around at home to take care of too. But thanks so much, and hopefully we'll have you on again sometime.
All right. Thanks, Dr. Brown. Have a great day.
Bye-bye.
Yeah.